much for participating today. I would like to introduce our speaker. Dr. Goddard is an alumni of Angela State University. She graduated with honors from the Texas Tech University Health Science Center, Masters of Science in Nursing Family Nurse Practitioner track. As a member of Sigma Theta Tau International Honor Society, she completed her doctoral degree at the University of Texas at Arlington. Dr. Goddard currently teaches in the graduate MSN program at Angela State University. She also maintains a clinical practice in the DFW area. She has taught in the graduate nursing program for George Washington University, Texas Women's University, and the Catholic University of America. Dr. Goddard is a member of the Fort Worth Nurse Practitioner Organization, Texas Nurse Practitioners, and the American Association of Nurse Practitioners. She recently served as an abstract reviewer for the NONPF 46th Annual Conference and also for the American Nurses Association Innovation Awards. She is a grant reviewer for the Texas Department of Agriculture, State Office of Rural Health Facility Capital Improvement Program. She is also a textbook reviewer for Jones and Bartlett Learning Publishers. She is a legislative ambassador for the Texas Nurse Practitioners Organization and also serves that organization on the Learning Management System Task Force. She was named as DFW Great 100 Nurses for 2020. She has publications coming out entitled The Emerging Role of Nursing Practitioners in Physical Medicine and Rehab in an Outpatient Skilled Nursing Facility in the Clinical Advisor Journal. She is a state and national presenter and recently presented at the Nurse Think for Nurse Educators Next Gen Learning Annual Conference and will be presenting later this fall at the next North Texas Nurse Practitioners Annual Conference at the Texas Nurse Practitioners Annual Conference. She is here today to present her latest research study on the moral distress among nurses employed in skilled nursing facility setting. There will be an opportunity for you to share your questions at the end of her presentation. Welcome, Dr. Goddard, and thank you so much for presenting today.
Thank you. Thanks for having me. I really appreciate it. So my study that I did examines the impact of moral distress among nurses employed in a skilled nursing facility, and therefore has implications on skilled nursing organizations and on the nursing profession itself. I became interested in this topic after I began working in a physiatry, which is physical medicine and rehab clinical practice. This study identified that the highest ranking cause of moral distress among nurses employed in a skilled nursing facility centered around clinical situations involving the end-of-life care. So our discussion today is also going to contribute to ethics knowledge and education. So our objectives will be to define the concept of moral distress, to identify situations that are high risk for the development of moral distress, and to identify symptoms of moral distress. Back in 1984, Andrew Jameson described moral distress as a situation that arises when one knows the right thing to do, but institutional constraints make it nearly impossible to pursue the right course of action. Moral distress can result from a perceived loss of personal and/or professional integrity due to the inability to achieve or sustain professional standards, resulting in the best outcomes for a patient, or the inability to advocate for the patient. Then moral distress is worsened by the sense of damage that could result from an unethical situation. The Nursing Code of Ethics mandates that nurses feel a responsibility and to act. Moral distress has been recognized as a serious problem and can have negative effects for nurses as well as for patients and for organizations. Being involved in situations with questionable ethical conduct, such as inappropriate treatments or causing undue suffering, can result in moral distress. And the literature has shown that a caring ethical environment is negatively related to the development of moral distress. Most of the research regarding moral distress in healthcare has been focused on acute care settings and environments. Continuing care environments are one of the least understood contexts of moral distress. So more attention needs to be paid on those practice areas. The healthcare system itself and the debilitated patient demographic group that are being treated in a skilled nursing facility, or SNF for short, cannot afford the consequences of losing those experienced, knowledgeable nurses. Moral distress can also cause delays in the patient's recovery and contribute to further complications and further functional decline. But there is a growing recognition that nursing staff in long-term care facilities experience moral distress, and end-of-life care is particularly a difficult situation ethically. So working in a SNF can be especially stressful due to the higher level of patient morbidity and mortality, and that continuous stress is worsened when the nurses perceive that there's inefficient time or resources to appropriately care for their patients. So research has shown that moral distress increases with the amount of time spent in direct patient care. There are numerous situations in the SNF setting that may cause moral distress. Katie was just saying for everybody to mute their mics. I think that would help. Thank you, Katie. So there are numerous situations in the SNF setting that may cause moral distress. Moral distress can be sparked by clinical situations, by internal constraints, or by external constraints, such as issues at the systems level. So it's vitally important that nurses with extensive geriatric knowledge are retained in their role and are able to provide quality care to a patient population that needs more time and more resources than the typical patient may. Moral distress has been found to be prevalent in the nursing staff who provide care for cognitively impaired patients. Productivity requirements are typically higher in a skilled nursing setting than in other practice settings, and nurses are being asked to offset decreasing reimbursement while still meeting quality standards, but in less time. So all that pressure is associated with an increase in moral distress. So common sources of moral distress could result from poor or inconsistent communication among healthcare providers, patients, and family, inadequate staffing, providing inadequate care to reduce cost. And then you can see some additional factors, some causative factors listed here on the slide. I won't read everything to you. Clinical situations in the SNF setting also may predispose to moral distress, like emotional distress surrounding quality and end of life. Patients with decreased functional freedoms that result from procedures such as joint replacements or fracture management, difficulty of the staff in responding to emergencies, and impaired cognition in older patients. Respect for autonomy, beneficence, non-malfeasance, and justice are ethical principles commonly seen in the long-term care setting. A lack of resources, including knowledge, finances, time, and access to doctors or NPs are frequent causes of ethical concerns in the long-term care environment. So the purpose of my study was to examine moral distress among nurses caring for the vulnerable geriatric population in the skilled nursing facility setting. And the second purpose was to describe the relationship between moral distress, common moral dilemmas, nurse characteristics, and job-related characteristics. This study adds to the field of knowledge by investigating moral distress in a diverse practice area. Moral distress is a substantial problem for healthcare. It can lead to physical and emotional problems for nurses, treatment errors, burnout, reduced retention rates, compassion fatigue, patient avoidance, and unhealthy work environments. Quality of care and patient safety may also be negatively impacted with moral distress. A quantitative cross-sectional descriptive design was used for my study, and the target population in my study included nurses employed in a skilled nursing facility that provided care for geriatric patients receiving rehab services, including physical, occupational, and/or speech therapy. All participants had a nursing license, were over 18 years of age, and were actively working, regardless of the number of hours, in a skilled nursing facility setting during the time frame of the study. Nurses at two facilities were sampled, the 120-bed Harrison in Keller, Texas, and the 112-bed Carlisle in Southlake, Texas. The facilities are described as a state-of-the-art transitional care center in a luxury resort-style residential setting. Permission was received from the administrator at both facilities. Data collection was face-to-face instruction, followed by another face-to-face collection of the survey. The MDSR questionnaire and explanatory cover letter were given face-to-face to a convenient sample of nurses employed in those two skilled nursing facilities. Participation was voluntary, assigned consent was obtained. The consent forms were kept separate from responses of the questionnaires. The survey took less than 15 minutes to complete, and it was completed off-duty. Additional questions that related to demographic data were collected, such as years of experience in the skilled nursing facility setting, age, the usual shift worked, usual number of patients per shift, race, and gender. Compensation in the form of a raffle was provided. The SPSS software was used to analyze the data. Scores for each of the Likert items were totaled and divided by the number of total participants to produce the mean score for frequency, intensity, and level of moral distress. Demographic data of participants was analyzed with the mean and range identified. The data will be stored for 3 years after the completion date of the study. Paper data was shredded, the data was de-identified, and the paper survey data was transferred into an electronic de-identified data file. So this is what the tool looks like. This is the MDSR, the Moral Distress Scale Revised. It's a 21-item Likert scale to assess the frequency and the intensity of moral distress. It was developed by Hamrick et al. It's a revision of the original 38-item survey tool that was developed by Corley. So the MDSR has 21 clinical situations scored with responses from 0 to 4 for frequency and also the intensity of moral distress symptoms experienced by the participant. The revision also has an open-ended question here that allows the researcher to gain information on additional situations that may cause moral distress. Additionally, inquiry into the participant's plan to leave his or her current position because of moral distress is included. This version also allows a composite score that can be used for multivariate analysis. The MDSR does have established reliability and validity. To obtain an overall moral distress score, the frequency score is multiplied by the intensity score, providing an overall moral distress score between 0 and 16, with the higher score being more indicative of increased frequency and intensity of moral distress. Of note, Hamrick et al. Published an updated version of this survey tool after data collection was completed on this project. The new tool is called the Measure of Moral Distress for Healthcare Professionals, the MMDHP. It explores excessive documentation and focuses on team and system issues. This tool that was used in my study predominantly looks at clinical issues. So practice settings for the new tool were only acute care units. So after discussions with the author, Hamrick, she's very interested in the results of this study utilizing a SNF setting, particularly if the study is repeated using her new tool. So we will see about that in the future. So the demographic data for the participant pool that took part in the study included an average age for the nurses of 39 years with a range from 24 to 58. The length of experience in the SNF ranged from 4 months to 25 years, with the average experience being 8 years. The sample demographic consisted of 45% of the participants self-reported as Caucasian, 9% of Asian, 5% were Hispanic, 27% African American, and 14% as other. 76% were female and 24% were male, and they averaged 17 patients in an 8-hour shift. So 29% of the respondents routinely worked a double shift consisting of 16 hours. The remaining majority, 71%, typically worked 8 hours. And of that, 36% worked days, 27% worked evenings, 10% worked nights, and 27% or a third worked a combination of all those shifts. So the mean frequency score was 1.29 with a range of 0.14 to 2.43 on the 0 to 4 scale. The situation with the highest frequency was having to follow the family's wishes to continue life support, even though the nurse believed it was not in the best interest of the patient. The mean intensity score was 2.28 with a range of 0.29 to 3.70 on the 0 to 4 scale. The situation associated with the highest mean intensity of moral distress was having to see patients that the nurse did not feel qualified to see. So of note, the entities of this study conduct conferences for an interprofessional team, patient and family, to discuss goals of care along with treatment options and decisions. So that may lower the moral distress seen among this study sample. The composite score, which was frequency times intensity for moral distress, ranged from 0.08 to 6.66 with an overall mean of 3.09 on a scale of 0 to 16. The situation with the highest level of moral distress centered around end-of-life care. Nursing, as we know, is a discipline of relationships involving moral practice, caring, and compassion. The situations involving unethical practices are just incongruous with nursing practice. Therefore, it's not surprising that system failures that conflict with nursing code of ethics would be upsetting and distressing, leading to moral distress. Now, let's take a look at the graph. As I mentioned earlier, moral distress contributes to negative consequences for nursing and healthcare, with decreased job satisfaction and work productivity, increased turnover, and burnout. So, consistent with other studies, nurses in this study had intentions of leaving their current position or had left a previous position due to moral distress. 14% said they had considered leaving their current job due to moral distress. 54%, so half of the sample demographic, had considered leaving a job due to moral distress. And 32%, or a third, had actually left a job due to moral distress. Now, a 2017 study by Shanafelt and Noseworthy found that replacing a nurse can actually cost a facility $88,000 when lost revenue is taken into account. So limitations of this study is that the sample was a convenience sample. Recruitment at the work site may have recruited participants that are more engaged in professional and work issues, as well as nurses who had more time to spend to complete the survey. So the sample may not necessarily be a representative sample of all nurses employed in the skilled nursing facility setting. Another potential limitation is that I did not control for individual personality differences that may affect moral distress. So implications for nursing. With proper support, nurses can create a climate that promotes safe, competent, and ethical care. Healthy environments that promote interprofessional relationships can reduce the presence and the impact of moral distress. So increasing the organizational support of ethics may be a key approach to reducing moral distress among nurses. Ongoing and open communication and support lessen moral distress. Successful models for dealing with moral distress are interdisciplinary, with mutual respect of and recognition of ethical dimensions of care. Organize sessions to problem solve and collaborate with peers and other involved professionals, development of an active ethics committee, and utilizing information that professional organizations put out are all strategies that will prevent or address moral distress. Patients and families should be able to discuss goals of care with the healthcare providers, along with considering appropriate and ethical treatment issues. So how hard has that become with COVID precautions going on? It would be interesting to repeat this study in the time of COVID and see if the moral distress among nurses has increased. The concept of moral distress lends itself to interdisciplinary education during nursing school, and that could be the foundation where nurses learn to identify and address ethical issues in an interprofessional manner in their future practice. Nurses should be taught to identify physical and mental symptoms of distress within themselves and others, and along with self-care measures. Mental health assistance programs should be a routine benefit in the SNF setting. And training on time management could be beneficial to reducing distress among nurses in this environment as well. Professional blogs and organizations are great avenues for nurses to get on and discuss ethical issues and their feelings about it. Entities should have processes that are clearly identified for nurses to have the ability to advocate to physicians and providers or organizational authorities on behalf of the patient. And then reflective and collaborative styles of management should be utilized in the SNF setting to help reduce moral distress. And then organized debriefing sessions following a difficult end-of-life case should be the norm in the SNF setting. So where do we go from here? Additional research is needed to identify evidence that supports strategies, best practice for the development of ethical environments in the SNF setting. More research and information is needed regarding the financial cost of moral distress on SNF entities. And then we need to utilize the new MMD-HP survey tool in the SNF setting to assess levels of moral distress from the clinical perspective with the MDSR that I use to a documentation team systems perspective with the new tool. So final thought, a wrap up here would be that nursing needs to take the lead, as always, in cultivating ethical climates that work within the reality of their individual workplace setting in order to reduce or eliminate moral distress, which ultimately could result in entire transformation of the healthcare system. All right, so any questions?